everyone. In this session, we are going to be proving regulatory grade workflow in AI-driven HCC coding. My name is Ritwik. I'm the co-founder of Martlet AI. I look over anything and everything on the business side of things. I will also have my co-founder join me, Hasham, during the second part of the presentation. He's the CTO. Let's go over what is risk adjustment in HCC coding as starters. So let's start with a question most people outside of healthcare have never had to think about. So how does an insurance company know how much money it actually needs to take care of its patients? So the answer lies in something called risk adjustment, which is a pretty complex concept. And at its core, risk adjustment is the process of accounting for the health status of patients when calculating insurance payments. So think about it this way: a health plan covering a population of relatively healthy 40-year-olds is going to spend very differently than one covering patients managing multiple chronic conditions like diabetes, heart failures, or let's say chronic kidney diseases. So risk adjustment ensures the system stays fair. Health plans that cover sicker, more complex patients receive higher reimbursements, and plans covering healthier populations receive less. It levels the playing field and it keeps the system financially sustainable. So now, why does it really matter? So three main reasons why it actually matters. So first, fair reimbursement. Like I mentioned, payers receive payments that is proportional to patient complexity, not just how many members that they cover. Without this, health plans would have a financial incentive to avoid enrolling the sickest patients. So, which is exactly opposite of what we want as a society. Second, better care planning. When a patient's risk profile is accurately documented, care teams can intervene earlier, manage chronic conditions more proactively, and ultimately deliver better outcomes. Accurate data drives much better decisions. And third, of course, regulatory compliance. This is, of course, not optional and is at the core of risk adjustment. So CMS, the Center of Medicare and Medicaid Services, mandates accurate risk adjustment for Medicare Advantage and ACA plan. Getting it wrong isn't just a revenue problem, it's a compliance and an audit risk. So where does actually HCC coding come in? So HCC stands for hierarchical condition category. It is the classification system CMS uses to group related medical conditions and assign a risk adjustment factor. Most people would know it as RAF to each patient. That RAF score directly determines how much a health plan actually gets paid for that specific patient. So here's the problem. Conditions that have to be documented and coded accurately every single year, for them to count, a patient's diabetes doesn't automatically carry over. If the physician doesn't document it in the visit, or the coder also misses it retrospectively, it doesn't get captured. And when conditions go uncaptured, health plans lose reimbursement. They are rightfully owed, and patients may not get the care management and attention that they need, so which creates care gaps. Between what should be coded and what actually gets coded is where the opportunity lies, especially for artificial intelligence as well. And that's exactly what we do at Martlet AI. So the challenge with HCC coding and why it's actually hard. So now we understand what risk adjustment and HCC coding is. So I'm going to be very direct that it is an extremely hard and very complex problem. And AI claims to have fixed it, but it really hasn't. So to put numbers in perspective as well, 25% of HCC conditions go uncoded every single year still, even after we have had advanced technologies in place in the space. So that means 1 in 4 chronic conditions that could have been documented, supported, and submitted simply aren't. Not because clinicians don't care, not because coders aren't doing their jobs, but because the system itself creates like barriers that make accurate, complete coding incredibly difficult to achieve at scale. So let's talk about why this actually happens. So the first challenge is volume and scale. Providers are reviewing hundreds of patient charts every single day, and these aren't simple, clean documents. They are longitudinal patient records spanning over years, filled with a bunch of unstructured clinical notes, lab results, discharge summaries, and specialist reports as well. So when you're doing this process manually, conditions, of course, get buried. They're often missed, not by mistake, but because no human can catch everything at that volume. And this is an extremely complex problem where accuracy needs to be super high. So then there's multiple rounds of reviews, but conditions still go missed and uncoded. So now the second one is time pressure. The window before a patient visit is extremely narrow. So coders and clinicians have limited time to go back through years of records and identify every relevant condition before the encounter closes. So once the visit is done and the claim is submitted, the opportunity to capture that condition for the year is essentially gone. Then the third challenge is documentation gaps. So this one is subtle but critically important. Conditions are often implied in the chart but never explicitly stated. A physician might note that a patient's blood sugar is elevated, or they have peripheral neuropathy, but never connect those dots to a diabetes diagnosis in the documentation. So chronic conditions go undocumented, uh, visit after every year. And if it's not documented for risk adjustment purposes, it doesn't exist. And the fourth challenge, and arguably the most consequential, is the audit risk. Every HCC code that gets submitted needs to be supported by what's called the MEET evidence. That stands for monitoring, evaluation, assessment, and treatment. If a condition is coded, but the chart doesn't contain traceable evidence that the provider addressed it, then the code is vulnerable, and CMS is going to trigger audits for that, which results in usually pretty high financial clawbacks. And with everything that has been going on this year and the last year, so CMS has explicitly announced that they're going to be auditing pretty much every health plan that's out there. So the challenge isn't just finding the missing conditions, it's finding them accurately, linking them to the evidence in the chart, and doing it at scale that is simply not achievable through manual review alone, or through legacy technologies that we had. Uh, so the two workflows for HCC coding and risk adjustment. So we know the problem is real and it is extremely expensive and it is getting harder to solve manually. The question now is, how do organizations actually approach it? So the answer comes in two forms, two distinct workflows, and where you sit in the healthcare ecosystem largely determines which one you rely on. On the left, you see prospective, and on the right, you see retrospective. Retrospective is where most organizations are today. After the encounter closes, teams usually go back through the historical charts in bulk, find the missed HCCs, link them to the evidence, and prioritize a chase list by draft left potential. It is systematic, it scales across larger member populations, but it recovers revenue that would otherwise be left on the table. For payers and health plans managing hundreds of thousands of members, this is an essential workflow. Prospective flips the model entirely. So charts are analyzed before the visit, gaps are surfaced at the point of care, and in the EHR or a platform that's connected to the EHR, the provider documents during the encounter, and then the code is captured before the claim is ever submitted. No chasing, no queries, no recovery needed. This is the workflow built for providers and health system who want to get it right the first time and also improve clinical documentation at source. Now, here is the important thing to understand. These two workflows are now not competing with each other. Retrospective finds what was actually missed. Prospective makes sure nothing gets missed. Coming to retrospective cleanup to prospective accuracy, so the direction is upstream. Like I mentioned, the industry is moving away from chasing and recovering and towards fixing documentation at source before the encounter ever closes. So look at the left side of the slide. In the retrospective world, coders are sending queries months after the visit. Physicians are responding to addendas, requests on top of already overwhelming workloads regarding what was earlier not coded, and then they need to fix it. So documentation gaps surface too late to be corrected. Revenue recovery is parallel at best, and critically, every missed coding cycle compounds your audit exposure, of course. You are not just losing revenue today, you're building a compliance liability for tomorrow. So now look at the right side. Same patients, same conditions, completely different story. HCCs are captured at point of documentation, providers prompted in real time, no burden, and now there are technology layers and integrations in place where we are able to do this in the EHR directly. So no separate portal for the providers as well. Revenues captured in the first submission cycle and every code evidenced at origin, making you audit ready from day one. The difference is not just operational, it is, of course, very strategic. And now, even if you see that most of the health plans are also moving towards prospective HCC coding, where they either do this process manually and then they send the output back to the provider to look at prospectively. So one model has constantly been catching up, the other puts you permanently ahead. And the question I want you to sit with as we go to the next slide is, what does it actually look like when a provider receives one of those real-time suggestions in the moment? Now I'll hand it over to Hasham.
In this talk, we'll focus more on the aspect of defensibility, because this is becoming increasingly important in medical coding altogether, especially in risk adjustment. So it's not just a matter of what if the code was accurate or not, or correct or not. It's also about, is it defensible or not? And that stems from the basic need of backing any code with evidence. So even if we talk about human coders, they slightly diverge in terms of their decision making. You can pass in the same example or the same document to two different coders, and you can get some different outputs. The outputs wouldn't be totally different, but there would be just very subtle differences. For example, this is a small note about a heart failure, and one coder can say, hey, it looks like a systolic heart failure, but the other one can say it's just unspecified. These are very subtle differences, but at volume, these can turn into maybe a huge difference in revenue or risk of audits, etc. So main thing is that whatever is coded, it's backed by the model, it's by suggestions and evidence from the document. If we go ahead and see, what does it actually mean when we say defensibility? A code has to be linked, it has to be explainable, traceable, and exportable. What that means is, first, for a given code, from where in, let's say a patient has 10 different documents that are being reviewed. Now we have 10 different codes from those 10 different documents. Now there would be multiple evidences for a single code in nearly all the visits. Let's say they're diabetic, right? Where in those reports or where in those documents is that evidence coming from? Like, where are the exact mentions of that condition following the meet criteria? Let's say their condition has been evaluated and they're on a drug. Now, where exactly in that full report, 10-page or 100-page document, does that actually say that they are taking a certain medication or that this particular condition was actually evaluated? That's the evidence span. In this document, on this page, in this section, this code was, or this condition was evaluated. This is why this code is being suggested. Now, this ties in with the rationale. Again, there could be many different mentions or many different phrases that could be supporting that meet criteria, but what actually makes up for it? Why was the code suggested? Yeah, let me give you an example. BMI. BMI has a very specific code, right? But just mentioning high BMI, is it worth it? Should we code it? Or does the provider also need to mention, hey, the person is obese? So that is where the rationale comes into play, and that is where the subtle difference also comes into play. That where do we actually, how is that code being suggested? Yes, the evidence is there, but what's the rationale behind suggesting or pointing to that evidence? So that's the second part of the rationale. Then we have provenance, which literally means keeping track of this entire chain. This was a code, this is the condition, this is the code, and this is the document, this is the page, this is the section, keeping full track of all of it. Then we have to now package it in a way, right? Let's say we have a code and we have evidence in 10 different documents, and all of that is good evidence. But then when we actually package it, because we have to submit, we cannot just submit all the documents, right? Because CMS has a rule that you cannot submit more than X amount of documents for a given condition. We then have to select which one or where in all the mentions or all the evidence, which one is the most suitable for this code that we can submit. That is the fourth pillar to it. So it all starts from finding the right evidence, then exposing the rationale, keeping trace of everything, and then selecting the right one as well. Now, if any of this breaks, it becomes really hard to defend a given condition or a code, because it has to be very transparent. What the benefit of this is, number one, it reduces audit risks, of course, because everything is already tied in well together. And obviously, it also improves your coding quality. So that is what it means by defensibility. how does that defensibility actually works across different workflows? So as Ritwik said, we have two different workflows, but we also have the RADV, which is kind of like a branch of retrospective. But we can still treat it separately because it has proactive versus reactive component to it as well. But the idea still remains the same across all different workflows. In the case of prospective, when a condition or a code is being suggested at the point of care, we have to go beyond just saying that, hey, here's the condition, here's the code, but where is it stemming from? So when a CCD hook or a pop-up is suggested to a provider in an EHR, they can literally click on it and see what's the trace of this particular condition. Let's say the code was diabetic. It's a prospect, like it's a suggestion. Now, what does that mean? So probably there's a high chance that that person has had high HbA1cs consistently in the past 10 visits. So that is where it ties in to that defensibility that, hey, here's the evidence that's available for that particular code. And the provider can literally see it. They can just see, click, and go to that chart back in time and see where the evidence is. Same is the case for retrospective. It's more straightforward because in the case of retrospective, you literally have to submit the documentation for each and every code. So otherwise you cannot even code. But yeah, the idea remains the same. And same is the case with RADV as well. We literally tie the evidence with each and every code and make sure that the evidence is strong enough so that it is defensible. That strong enough is actually, it stems from what I said in the previous slide because it's a bit more nuanced, and we'll go over that. In the case of prospecting, what do we usually do? What's the workflow that we work on or what we have developed? It's mainly about when we pull or process all the data of the patient, what we call the patient context. We pull history, their lab results, maybe radiology reports, etc., and those are processed. And then real-time prompts are actually shown to the provider right inside their EMR or their EHR, and then the provider can take an action. There are multiple ways to take an action, like there are multiple actions, like they can either just select it, they can do a follow-up, like they don't need to select the code or the condition right now. They can say, hey, I want more clarification on it. Or they can, if it's a recapture or something, they can just put it in an assessment and then close the gap. Or there's one other thing, and that is if there's any care gap, like for example, the person has a history of cancer or something, then probably they need some screening like breast cancer or anything for that matter. That is where the traceability fits into the prospective engine. The second workflow, retrospective workflow, also it's the same with RADV. It's like I said, it's mainly about surfacing. First of all, we have to identify the charts or the patients that have high risk conditions or where the traceability or the evidence submitted, where the evidence is not clear enough. Because it's retrospective, what that means is that a lot of codes or a lot of it has already been coded by the provider themselves, right? So, but now we're doing retrospective, which means that we will find issues in this particular set of documents so that we are able to back codes. Basically, it's a 3-step workflow. It's basically validate, add, delete. So we validate what was already there. If not, then we would say this is invalid. If anything is missed, then we add and delete again if anything is invalid. So every HCC needs to be valid, and then we have to basically assemble the packet for submission. And like I said, defensibility is already baked into this because we cannot just suggest any code, or even in the case of let's say validate. Validation doesn't really mean that, hey, is it valid or not, but why is it valid? That's the whole point, right? So that's a retrospective workflow where we take in existing codes and we try to validate, add, delete. And then we assemble the packet, link evidence together, prepare a provenance report that this was received, this is what was done, and there's a user, like a human in the coder workflow, where humans can also review this and look at whatever is done by the AI in real time, and then make suggestions, they can take any action which includes maybe correcting an error that has been made by the model, or adding any new stuff, anything that was missed by the model, or even in the defensibility chain, if something wasn't tagged properly. That is also something that the users can do. In terms of what do we do unique, or how do we position it, it's mainly about focused on evidence linking. That's the main point, be it, again, prospective, retrospective, RADV. The main thing is evidence linking. It cannot be, we're not just suggesting any code that's without any evidence. And it has to be down to the very place in the document. Could be multiple places. For example, in our workflow, we say in this document on this page, it has been mentioned on these many times. In this document on these pages, that's it. the condition has sufficient evidence on page 1, then page 5, then page 10. It's especially true with retrospective workflows where the charts are very noisy because all the charts are probably bundled in a single PDF, and you're reviewing the PDF. In that case, it becomes really easy if the model or the AI has done that first pass and they've already linked all the evidence, and it's just presented to you that in this particular document on this page, you'll see evidence for this code, for the next code on this document on this page. So that's the whole point. Then again, the submission packet needs to follow CMS guidelines. Documents are allowed, or we just simply cannot. Now the guidelines are very strict, so we cannot just simply allow any unlinked chart altogether. So we'll just drop a bunch of things. Like I said, we have to pick the best evidence out of all the ones that are available, and then we can do these tests internally. Like we can have mock tests inside the organization for RADV, and then we have deployment control in the sense that everything could be either offered as a SaaS, or it could be deployed inside your environment, so it's totally controlled. Data doesn't go out, and that's the highest form of privacy control. And yeah, that's how we do it at Martlet. Now, there are two things. How do we define what's submission grade defensibility? What's defensibility in the first place? So, like I said, we do it in simple 3 ways: validate, add, delete. And we've done this study across multiple customers, and these are just some of the numbers that I would want to share with you. And that is, we took 100 different patients. This is a retrospective review, and we ran it through the pipeline, through the AI, and we had them reviewed by a human coder or a validator. And the codes that were accepted were the ones where the model suggested that those codes those are correct, and yeah, those were just accepted. Then we combine the codes which are either added or edited. What that means is, for example, the model made a mistake, and instead of E1165, it was just E119. I mean, instead of type 2 diabetes with hyperlipidemia, it was just, let's say, type 2 diabetes, unspecified. Now that's an edited code, right? Because a better version of that code is available. Or it was missed altogether. So these are the 2 categories which fall under the edit one, where the coder actually had to do something different and correct the model. So you can see the results. And now the last thing is I want to go over is so this is the retrospective one. So we can very easily calculate the numbers. Like when you calculate precision, recall, F1 score, accuracy, whatever our benchmark is, very simple. But in the case of prospective, it gets a bit difficult because it's more about for example, the model or the AI suggested a code, and that code or that condition is perfectly valid, but it might not make sense to code that right there and then for the provider. Maybe they would want to offer, maybe they would want more clarification on it. Maybe they would say, hey, the HbA1c is high, but maybe order another lab or order some more tests that would clarify something. Or they would want to wait more and then code the same condition later in a follow-up visit, or they would want to, just suggest a diet plan, or anything for that matter. All of these actions can lead to the final selection of that condition later on. But if in some cases that condition can even be avoided, let's say if it's a diet plan change, then probably that condition might get resolved. Let's say it's obese and now they're improving. You don't need to code probably. It all depends on the provider. So it becomes a little fuzzy in this situation. How do we actually calculate what's the final selection ratio when we are suggesting any codes? Because it's not a one-to-one mapping. In certain cases, in very limited cases, yes, you can get a mapping where sufficient evidence was already available and the provider just missed it. That is one option, yes, and that's the first error that you see on top. Yeah, that's the simple one to calculate, but all the other ones are a bit difficult. But does that mean that it's not there or the AI is not being adopted? Not necessarily. This is a more nuanced study, which requires a whole discussion on itself. But yeah, that's essentially it. So basically, what we're talking about is the focus on defensibility, how it ties into different workflows in risk adjustment and HCC coding, and what's the benefit of it, and how do we approach it. Thank you.